I'm Dr. Neil Skolnick, and we have got another great issue of Diabetes Core Update this month, beginning with an article from Diabetes Care on the effects of semaglutide with and without an MRA in participants with type 2 diabetes and CKD. This was a flow trial pre-specified secondary analysis. Then we're going to talk about two articles from the New England Journal on Orforglipron, which is a small molecule GLP-1 receptor agonist, an oral small molecule GLP-1. And we're going to talk about one article that discusses its use, the trial in early type 2 diabetes, and the other, the trial in obesity. Then an article from Diabetes Care on dementia risk in people with type 1 diabetes, and looking at what the associated risk factors are for dementia in that group. Then an article from Diabetes Care on the impact of baseline GLP-1 receptor agonist use on albuminuria reduction and safety with simultaneous initiation of Finerenone and Empagliflozin in type 2 diabetes and CKD. And finally, an article from the New England Journal of Medicine on oral semaglutide at a dose of 25 milligrams in adults with overweight or obesity. Let's jump in. For our first article, we're going to discuss the effects of semaglutide with or without concomitant mineralocorticoid receptor antagonist use in participants with type 2 diabetes and CKD. This was a flow trial pre-specified secondary analysis published in Diabetes Care. In the flow trial, semaglutide reduced the risk of major kidney and cardiovascular outcomes and all-cause mortality in people with type 2 diabetes and CKD, a critically important endpoint and trial that we've discussed previously. In this pre-specified analysis, they assessed the effects of semaglutide on kidney, cardiovascular, and mortality outcomes by baseline MRA use. Participants were randomized to once-weekly sub-Q semaglutide 1 milligram versus placebo. The primary kidney outcome was a composite of time to first persisting greater than or equal to 50% eGFR reduction from baseline, kidney failure or death from kidney or cardiovascular causes. Baseline MRA was predominantly spironolactone. Finerenone use was only available after recruitment ended. So what were the results? The effects were analyzed by baseline MRA use. Semaglutide reduced the risk of the primary kidney outcomes by 49% and 21% versus placebo in the MRA and non-MRA subgroups, respectively. There was no heterogeneity favoring the effects of semaglutide on major adverse cardiac events, MACE, and all-cause mortality in both the MRA subgroups. Albuminuria at 104 weeks was reduced from baseline with semaglutide by 15% of the MRA users, 33% in the non-users. Estimated eGFR decline was similarly reduced with semaglutide. John?
So Neil, some interesting on kind of two different levels. One, semaglutide showed that it helped with some kidney outcomes. So that's really nice because it is a really good workhorse diabetes medication, that it lowers A1C, 1.5, weight loss, all the other good things with it. Interesting in that Finerenone really hadn't made it to the scene yet. So, what does it tell us? Well, I think spironolactone never really got the embrace it should have in a couple different areas. It's a really good CHF medicine. That study had come out long after it had become a generic product, and I don't think it was as embraced because I think people were worried about some hyperkalemia, which probably is not as big a worry as people can have. And it's really emerged in the literature kind of more lately for people who have resistant hypertension. So, and this said, in our patients who might be on semaglutide that we need to add this to. Now, KDIGO, the guidelines really talk about using this in people whose GFR is greater than 45. So not really tracking this particular MRA medicine, tracking it down to the lower GFRs. But if we have someone on it for resistant hypertension, if we have someone on it for congestive heart failure who's also on semaglutide, we can feel pretty confident that we're going to have some of the good outcomes. We're going to hear a little bit more about Finerenone later in the program.
Next, joining us today to discuss two critically important articles published in the New England Journal is Ajay Rao, who is Chief Section of Endocrinology, Diabetes, and Metabolism at the Lewis Katz School of Medicine at Temple University. The articles we're going to discuss are Orforglipron, an oral small molecule GLP-1 receptor agonist in early type 2 diabetes, and Orforglipron for obesity treatment. Ajay, welcome to our podcast.
Thanks for having me on, Neil. I really appreciate being on.
This is such a great topic. Let's start with background because a lot of people don't actually know what Orforglipron is. Can you tell us a little bit about it?
Sure. Just another sort of added armamentarium for us in helping out people with diabetes, living with diabetes and obesity. Obviously, I'm sure many of us all know the availability of the GLP-1s that are available, the GLP-1 receptor agonists. And a lot of us know of the injectable forms, and some or many of us know about the oral form that's tried to mimic the compound that's given via injection. This is actually a small molecule version of that peptide, so given by mouth, and perhaps not riddled with the finickiness of the oral one that's already on formularies, the oral semaglutide.
Yeah, and it's fascinating. So it's because it's a small molecule, it's absorbed more readily. Let's start with each of the articles in turn. First, let's go over the diabetes article. Tell us about the methods relatively briefly, and then we'll get to results.
Yeah, sort of your standard phase 3 study in utilizing this molecule. So in the study that was focused on people living with diabetes, they really were harnessed against those who had early type 2 diabetes. So interestingly, individuals who are diet managed with type 2 diabetes, not on other agents. And essentially, they randomize these individuals into getting a variety of doses of the novel agent and, of course, placebo, with the concept of obviously looking at, because it's diabetes, looking predominantly at how good did the drug do with A1C lowering. And of course, they also examined the potential changes in weight.
And what did they find?
So I think pretty fascinating. I think with the 3 different doses, they found a pretty good drop in A1Cs in less than a year. So they were looking at it about the 40-week point, so a little bit probably at the 9-month point roughly, or 10-month point, and they were able to see a drop of about 1.25 to 1.5 A1C depending on the dose that was used. Because again, they used 3 different doses compared to maybe just about a half a point drop in those who are on the placebo arm. So clearly a nice drop in A1C, which was really nice to see. And also with the new diabetes medicines, also great to see the fact that they also had a nice drop in weight also.
Yeah, that makes it pretty exciting. Let's move on now to the obesity trial. Methods first and then results.
Yeah, so this one, and again, same compound, same idea, but here the focus was for treatment for individuals with obesity. And again, here it's a randomized double-blind trial, and they looked at 3 different doses, again, of the same compound compared with placebo. And remember, it was an adjunct to healthy diet and physical activity for a little bit over than a year. All of the individuals in this study had obesity, but they did not have diabetes mellitus. And in this one, the primary endpoint was essentially the change in body weight from baseline to week 72.
And what did they find?
Again, a pretty profound drop in weight, close to 7.5 to about 8.5 to 10%, depending on where you started out with which dose. And that's compared to only a 2% drop in body weight from baseline in the placebo group. So again, a really good effect on weight. And of course, with that, you saw a drop in other parameters such as blood pressure, triglyceride levels, cholesterol levels. They all did much better than those who were receiving sort of placebo.
Very good. And side effect profile, any surprises here or usual
Yeah,
GLP-1 sort of
great.
side effects?
Yeah, great question. And I didn't comment on that on the both studies. I think you saw the similar sort of thing that we see on the GI side, nausea, aspects related to the GI tract. And that did lead to some discontinuation, but nothing, I think, surprising compared to even the available forms of the oral peptide or the injectable peptide of the GLP-1.
Great. So let's now go to clinical implications, which is
Yeah.
always what people like you and I are
Yeah.
most interested in. What do you see as the clinical implications of these trials?
Yeah, I think just a great question and another added resource that we can turn to. I think we are all seeing these patients and they're all asking for assistance, and we know that individuals with the overweight obesity represent a big problem for healthcare. I think starting out with the individuals with diabetes, I think it's another added potential option. I do want to say that this trial that we looked at was focused on those who are diet managed. So I think it would be interesting to see how this synergizes with other therapies that we
Hmm.
typically think of first line. But this is usually the first type of study done in diabetes to just demonstrate that it's doing its job of A1C lowering. So I would like to see how it synergizes with other available therapies like metformin and SGLT2 inhibitors and other types of regimens. But again, it's really nice to see that A1C drop in a short period of time. And with the known cardiovascular benefits of GLP-1 class, it's really nice to see that for the diabetes study. I think for the obesity study, this is such a huge population. And surprisingly, we have had oral agents on the diabetes side for the GLP-1, but I must say the uptake has not been great. And I think if this molecule is not as finicky as the available one on the market, I think this will be a game changer for those who are really averse to the injection aspect of things.
And when you say finicky, what do you mean by finicky?
Yeah, great question. I find the available one, it's a peptide, right? It's not a small molecule like this one. So that peptide, we're trying to do the same thing that you would do if you were getting it via injection and not let it get attacked by your own GI tract as it passes through. So I do think that as many for that available compound on the market, it has to be taken in a certain way on an empty stomach outside of these other meds. And that becomes, I think, really hard for patients. And I'm hoping that this will be a little bit easier because it's a smaller molecule and doesn't maybe have that sort of regimented approach when you're taking it.
I couldn't agree with you more. This is exciting. GLP-1s have become a mainstay of our treatment for diabetes as well as treatment of obesity and oral options. And later in this podcast, we are going to discuss oral semaglutide. Having two oral options potentially coming to market if they are FDA approved over the next year to year and a half really is exciting for patients. Not everyone loves injections, and it just makes it hopefully easy to use and easy to move forward with. Jay, thank you so much for joining us.
Anytime, Neil. Thanks for having me on. Have a good one.
Our next article is from Diabetes Care, and it looked dementia risk in people with type 1 diabetes and associated risk factors, and nationwide registered based cohort study. So this was a cohort study of over 43,000 individuals who had type 1 diabetes in Sweden, and there were 217,000 plus age, sex, and county matched controls from the Swedish total population register. They used Cox regression to study the relationship between type 1 diabetes and risk of all-cause dementia and dementia subtypes: Alzheimer's, vascular, non-Alzheimer's, non-vascular dementia. The researchers also examined the relationship between various risk factors and the risk of all-cause dementia in patients with type 1 diabetes. The patients were followed for slightly over 14 years with a range of 7.9 to 20. Dementia was recorded in 1.2% of the individuals with type 1 diabetes and 0.9% of the patients who were in the control group. Age, sex, and county match controls were brought into that. Compared with the controls, individuals with type 1 diabetes had a higher risk of all-cause dementia, a hazard ratio of 2.02, Alzheimer's, 1.38 hazard ratio, vascular dementia, hazard ratio of 3.73, and non-Alzheimer's, non-vascular dementia, hazard ratio of 1.87. The risk factors related to dementia and type 1 diabetes beyond age were patients with a lower education level, being single, having a higher systolic blood pressure, a higher A1C, a history of a previous stroke or TIA, and a history of cardiovascular disease or a longer duration of having diabetes. Neil?
John, it's interesting. You and I have talked actually many times on this podcast about the relationship between type 2 diabetes and dementia, that you have about twice the incidence of dementia in people with type 2 diabetes, and it is that risk is related to A1C control. It's less in people with good A1C control. We don't think of it as often in type 1 diabetes, and this adds to the literature in that area. Dementia is just like nephropathy, neuropathy, retinopathy. It can be thought of as a downstream complication of diabetes. And one of those things that we talk to people about as a reason to try and have tight control, which brings us to modifiable risk factors. And I don't think it's surprising, but it's important to emphasize that two modifiable risk factors identified in this paper were A1C, again, another reason to have good A1C control in people with type 1 diabetes, and systolic blood pressure to aim for that type blood pressure control. Our next article from Diabetes Care is titled "The Impact of Baseline GLP-1 Receptor Agonist Use on Albuminuria Reduction and Safety with Simultaneous Initiation of Finerenone and Empagliflozin in Type 2 Diabetes and Chronic Kidney Disease, the Confidence Trial." The Confidence Trial demonstrated an additive benefit of simultaneous initiation of Finerenone, which is a non-steroidal MRA, and an SGLT2 inhibitor compared with monotherapy in reducing the urinary albumin to creatinine ratio, the UACR. This was a pre-specified analysis that evaluated whether safety and efficacy of combination therapy varied by baseline GLP-1 receptor agonist use. Why is that important? Because these are medicines that are commonly used. So they looked at adults with CKD with a UACR greater than or equal to 100 but less than 5,000, and an EGFR 30 to 90, and type 2 diabetes with an A1C less than 11%, and individuals randomized 1-to-1 to once daily Finerenone, Empagliflozin, or both Finerenone plus Empagliflozin. Among 800 participants in the trial, 23% used a GLP-1 receptor agonist at a baseline. At day 180, UACR changed from baseline in participants using a GLP-1 receptor agonist was negative 51%, with combination therapy negative 34% with Finerenone and negative 36% with Empagliflozin, and corresponding results in those not using a GLP-1 receptor agonist at baseline were essentially similar. Hyperkalemia incidence rates with combination therapy were 9% and 9.5% among individuals with and without baseline GLP-1 receptor use. EGFR changes were consistent among individuals with and without baseline GLP-1 use. John?
So, Neil, I think an interesting study. So you and I are involved, once a year in the top articles kind of presentation to a primary care audience. The Confidence Trial was one of the articles we talked about as a top article of the year. It was in the late August New England Journal of Medicine. And in that combining Empagliflozin and Finerenone in a patient population with diabetes and kidney disease showed an additive effect of adding in those two medicines versus either one as monotherapy. I think if you look at what are our challenges here in primary care and taking care of people who have kidney disease, the numbers for survival for people with stage 5 kidney disease hasn't changed a ton. And, the average lifespan in that population is and has been around 5 years without transplantation or something else going on. And that number really hasn't moved a lot, despite all these kind of great advances we've had. So the challenge is really for you and I, when we have people who are CKD3, CKD4, can we stop the line? Can we reverse the line a little bit and stop people from progressing into CKD5? A lot of our patients are on GLP-1s, right? They are a really good workhorse, strong medicine for A1C reduction. So the context of this is if you have, populations and you look at people who are on baseline GLP-1 versus not on a baseline GLP-1, does this kind of peanut butter and jelly combination added into a GLP-1 present or absent patient, does it really screw up that synergy? And it really doesn't seem to. So whether someone's on a GLP-1 didn't really affect some of the positives that you saw. Our next article is from the New England Journal of Medicine, and it was a study looking at oral semaglutide at a dose of 25 milligrams in adults with overweight or obesity. So this was a 71-week double-blind randomized placebo-controlled trial that was conducted at 22 sites in 4 countries. The researchers enrolled patients without diabetes who had a BMI of 30 or higher or a BMI of 27 or higher with at least one obesity-related complication. Participants were randomly assigned in a 2-to-1 ratio to receive oral semaglutide 25 milligrams or placebo once daily. Both groups were given lifestyle interventions. The co-primary endpoints at week 64 were the percentage change in body weight and a reduction in 5% or more body weight. Confirmatory secondary endpoints included reduction in body weight of 10% or more, 15% or more, and 20% or more, and the change in the impact of weight on quality of life clinical trials version, the IWQOL Late CT physical function score. So there were a total of 205 participants that were randomly assigned to receive either oral semaglutide, and 102 were getting placebo. The estimated mean change in body weight from baseline to week 64 was a decrease in 13.6% in the oral semaglutide group and a decrease in 2.2% in the placebo-controlled group, an estimated difference of 11.4 percentage points. Participants that were in the oral semaglutide group were significantly more likely than those in the placebo group to have body weight reductions of 5% or more, 10% or more, 15% or more, and 20% or more, and have an improved physical function score. The GI adverse events, much more common in the oral semaglutide than placebo, 74% versus 42%. Neil?
John, I got to tell you, I think this is exciting. Looks like we may have an oral effective option for treatment of obesity, and that would be very welcome. So oral semaglutide at a dose of 25 milligrams, achieving a 13.5% mean weight loss is about what we saw in the step 1 trial of sub-Q semaglutide, in the big trial in people with obesity without diabetes, where they achieved approximately a 15% weight loss. So in terms of weight loss efficacy, these are about the same. In this trial, we saw a third of people lost greater than 20% of their body weight, and very important, we saw improved physical function. Based on this trial, Novo submitted oral semaglutide to the FDA in May, just a few months ago, for approval for treatment of obesity. Also, interestingly, just about a week and a half ago, oral semaglutide 14 milligrams, which is the dose for diabetes, not for weight loss, the 14 milligram dose received FDA approval for an indication of cardiovascular risk reduction in people with diabetes and elevated cardiovascular risk based on the SOUL trial, which showed a 14% reduction in MACE, which is what we see with GLP-1s in general in the CVOTs. Also, interestingly, in the FDA application back in May, this 25 milligram dose, the application also included an application for reducing the risk of MACE in adults with obesity and established ASCVD. Remember the SELECT trial, which we've talked about, it's 2 years ago already, fall of 2023, that was the large trial of semaglutide sub-Q 1 milligram in people with obesity and cardiovascular disease, either MI, stroke, or peripheral vascular disease, decreasing MACE by 20% over about 3 years. So we're going to see a lot happening in this space. Earlier in this podcast, we talked about another oral GLP-1 as well. It is very possible at the end of the next year to year and a half, in addition to our injection armamentarium, we will have 1 and perhaps 2 oral GLP-1s to help our patients who have obesity. John, before we close, I want to share some important news with our listeners. As you know, in addition to diabetes, we've been covering the full range of cardiometabolic conditions, and so our name is going to be changing to meet that consistent mission. Our podcast will be rebranded as Diabetes, Obesity, and Cardiometabolic Update. I know. You're already thinking, and you're right. The new name is Doc Update, Diabetes, Obesity, and Cardiometabolic Update. You'll notice this when the change is made on your subscriber feed. We'll have a new title and branding, same great information. For more information and links to the articles that we discussed in this issue, just go to diabetesjournal.org. Until next month, keep listening
and keep learning.